Okay, so this is one of our very few diagnosis-specific talks. And I think it's well-deserved. I think cardiac tamponade does deserve some special focus, especially when we're talking about echo diagnosis of tamponade. You can think of cardiac tamponade as cardiac compartment syndrome. Physiologically, what happens with tamponade is that in diastole, the pressures around the heart, whether that be within the pericardium or even outside the pericardium, the extracardiac pressures exceed the pressure in the chambers, causing impairment in cardiac filling. So tamponade is a diastolic problem. And the diagnosis of tamponade revolves around identifying a plausible etiology and identifying tamponade physiology on echo. And so we're going to focus on both these things, but really on the latter part, identifying tamponade physiology. So when we think about the specific etiologies, everyone thinks about pericardial tamponade. They think about pericardial effusions in particular being the etiologic factor that leads to tamponade. But remember that anything outside of the heart that exerts a compressive force into the heart can cause tamponade. So not only stuff within the pericardium, but also stuff outside. So mediastinal hemorrhage, especially if you take care of post-sternotomy patients in the ICU, mediastinal hemorrhage leading to tamponade is a dreaded diagnosis, but one that you need to make. And it's not a pericardial issue, it's a mediastinal issue. Similarly, masses in the mediastinum, especially those that are relatively fast growing, can cause tamponade as well. So really anything around the heart can cause external compression and lead to impaired filling and tamponade physiology. So what is tamponade physiology, at least on ultrasound? So there's three things that we should be able to identify on ultrasound to lead us to the diagnosis of tamponade. We talked about the first two in the basic talk. We talked about identifying diastolic collapse of the right ventricle. We talked about identifying collapse of the right atrium, which occurs during ventricular systole. We're going to go on to a third modality here, which is a Doppler modality, and that is the identification of mitral inflow variation. Now, all these things are clues on echo that leads to the diagnosis of tamponade. And if you start from top to bottom, which we'll get into, the stuff on the top is more specific, and you get more sensitive and less specific as you go down. So first, let's talk about diastolic RV collapse. So this is what most people think of as the sine qua non finding of tamponade on echo. It's the most specific ultrasound indicator of tamponade. So what happens is you get collapse of the right ventricle, specifically the right ventricular outflow tract in early diastole. So it's early diastolic collapse. So just as the mitral valve and tricuspid valve open, you get collapse of the RV. And the part of the RV, the wall of the RV that's the most susceptible is the RVOT. So what you're looking for specifically is early diastolic collapse of the RVOT. So the views that get you a good visualization of the systole versus diastole and a good visualization of the RVOT, those are the views that'll be the best to identify tamponade. So the ones that we use most often are the peritoneal long axis view, where the RVOT is right there near your probe, real superficial on the field. You can also use the peritoneal short axis view, angled upward to the level of the aortic valve. And then, of course, we're going to talk about using M mode to identify diastolic collapse of the RV. So here is an example of right ventricular outflow tract collapse in early diastole. So we're looking at a peritoneal long axis view. Clearly, you can see a large circumferential pericardial effusion. And if you look here at the RVOT, it looks like a trampoline that someone's jumping on. So you can see that there's collapse there of the RV outflow tract. Now, the question is this collapse occurring in systole, which would indicate just a hyperdynamic RV from volume overload or something like that, or volume depletion or something like that? Or is this collapse occurring in diastole, which would be suggestive of tamponade? So the best way to identify systole versus diastole on echo is to have an EKG tracing and to correlate with what's going on with the heart with what's going on with the electrical activity. So is this collapse occurring during the T wave? But oftentimes we will not have EKG tracing on our views. So if you don't have EKG tracing, the best way to identify systole versus diastole is to look at the valves. So if you look at the mitral valve, right, systole is when the mitral valve is closed, and diastole is when the mitral valve is open. So what you're trying to do here is you're trying to see, is this collapse occurring when the mitral valve is open? And it's a difficult call to make because it's always difficult to focus on two things at the same time, especially when those two things are moving, especially when those things are moving fast. So if you have a heart that is tachycardic, which is often the case in the setting of tamponade, it may be difficult to figure out what's going on with this while you're looking at the mitral valve. So your options are you can either get a video recording of this and play it back in slow motion at like half speed, or just go frame by frame. Or, as you know, the best way to visualize the movement of multiple things at the same time is by using M mode. So what you would do is you would take your M mode line in your peripheral long axis view, and you would put it down through your objects of interest. So in this case, the objects of interest are the RVOT and the mitral valve. So you would turn on M mode and put your line down through the RVOT wall and through the anterior leaflet here of the mitral valve. So this way you can time what's going on with both of these things simultaneously. So if we look at the structures that this line is going through, it's going through the pericardium, through the pericardial effusion, through the RVOT free wall, through the RVOT itself, the chamber, through the septum, through the LV chamber, and finally through the mitral valve. So these are the structures we're looking at here. Here is the RV free wall. So again, pericardium, pericardial effusion. There is the RVOT free wall. There is the RV chamber. There is the septum. Here is the LV. And then this thing here, moving up and down, is your mitral valve. And you can see this is the anterior leaflet of the mitral valve. This is the mitral valve opening as it goes up and slaps up against the septum. And this is the mitral valve closing. So closed mitral valve, open mitral valve, closed, open, systole, diastole, systole, diastole. So if you look at these two structures and see what's happening here, you can see that this collapse, this downward movement of the RVOT is occurring at the same time as the mitral valve opens. So just as the mitral valve opens, that collapse is occurring. So this is definitively early diastolic collapse of the RVOT. And this is very concerning for tamponade. This is tamponade physiology. Okay, so M mode really helps you figure out if what you're dealing with is true diastolic collapse of the RV. This is that personal short axis view. So if you, for whatever reason, can't get the long axis view, but can get a short axis view, what you can do is you can actually anteriorly angle up to the level of the aortic annulus and the level of the tricuspid valve. And so what we're looking at here is right atrium, tricuspid valve, right ventricle. There is the RVOT here, pulmonic valve. So you can see here the RVOT is collapsing. And it is occurring when that tricuspid valve, which is a little bit tougher to see, is opening. You can put M mode down these two structures as well, down through the RVOT and down through the tricuspid valve to time what's going on, but it's the same idea. This view is typically harder to get than the basic peritoneal long axis view. So it would be very rare for you to be able to use this view and not the other one, but this is another option for visualizing tamponade, visualizing diastolic RV collapse specifically. So that's RV collapse. What about RA collapse? So like we said, normally the right atrium fills during systole. So at a time when it's supposed to be filling, it's actually collapsing. So what you see is systolic collapse of the right atrium. This is something that occurs earlier on in the evolution of tamponade, and it is a more sensitive indicator of tamponade, but because other things can cause RA collapse, it is less specific. Okay, so you're able to identify tamponade earlier by visualizing RA collapse, which would happen before RV collapse, but it's less specific. So again, those views that get you the best visualization of the right atrium are the best views to look at this. So your apical four-chamber view typically is the one we go to. Subcostal long axis view is also an option. So here's an example of right atrial collapse. So again, you see a apical four-chamber view. Again, you see a rather large circumferential pericardial effusion. And then right here, here's the right atrium. And you can see that that free wall is sort of involuting, almost as if someone's lying on their back and kicking in that right atrial free wall. So this is collapse of the right atrium. And the way to time systole is either to look at the chamber up here, to look at the closure of the tricuspid valve, or to look at the TAPSE. So if that collapse is occurring when the tricuspid annulus is moving up or when the tricuspid valve is closed, then that is systolic collapse. That looks to be the case here. Okay. So systolic right atrial collapse occurs earlier on in the evolution of tamponade. So you can identify tamponade earlier, but it is less specific than diastolic RV collapse. So just to review, the utility of picking up chamber collapse is dependent entirely on your ability to differentiate between diastole and systole. So like I said, if you have EKG tracing, you can use it. If not, keep your eye on the mitral and tricuspid valves. Okay. In the peripheral long axis view, look at the mitral valve opening and closing. You can also use tricuspid valve in your apical 4 chamber view. Okay. And like I said, you can either record a video and play it back in slow motion or frame by frame, or you can just put M mode down your objects of interest and look at their motion over time. So what if you haven't seen chamber collapse yet? Is there something that you can use to pick up early evidence of filling problems? So what we do is we borrow this technique from the diastolic evaluation of the heart, because this is a diastolic problem. And we'll have a focus talk on diastolic evaluation, but this is just a small piece of it. So what we look at is we can look at blood flow velocities going from the atrium into the ventricle during diastole. Okay. So one of the ways that we can do that is to use pulsed wave Doppler to look at the velocities of blood flow going from the left atrium to the left ventricle. So we do this in the apical 4 chamber view. The apical 5 chamber view is depicted here, but for our purposes, the apical 4 chamber view. Apical 4, turn on pulsed wave Doppler, and you're going to put your sampling volume just above or just at the point of the open mitral valve leaflet tips. So where those tips open up, that's where it's at that level where you want to put your pulsed wave Doppler sampling volume. Okay. And what you're going to see is in diastole, you're going to see blood moving from left atrium to left ventricle in a biphasic manner. Okay. And again, we'll talk about this in depth during the diastolic talk, but very briefly, what you're seeing is this E wave here. This is the initial movement of blood from left atrium to left ventricle just after the mitral valve opens. And this flow is passive. This flow is driven entirely by the pressure gradient that has been generated between the now filled left atrium and the now empty left ventricle. So when that mitral valve opens, the pressure is higher in this chamber than it is here. And so blood moves in passively along the pressure gradient. And that creates this first wave here, the E wave. You then have a little bit of a pause, diastasis. Then you get your P wave and you get your atrial kick. And, a portion of the remaining blood is then pushed actively by the contracting left atrium into the left ventricle, creating the A wave. In a normal heart, most of the flow in diastole occurs passively. So the E wave is bigger than the A wave. Okay. And again, like I said, we'll get to that in the diastolic talk in more detail. So we're interested in looking at passive inflow, because what we're trying to look at is we're trying to see, is the extra cardiac compression that may be there from an effusion or something like that, is that causing impairment in passive filling of the ventricle? So we look at the E wave. And specifically, here is what it looks like in real life. But specifically what we want to look for is we want to look for respiratory variation of mitral inflow velocities. Okay? So what we'll do is we will get this tracing here, E and A. We're going to slow down our sweep speed, our Doppler sweep speed. So what that will do is it will give you a bunch of E waves in the same tracing across the respiratory cycle. So you'll see E waves when the patient's breathing in, and you'll see E waves when the patient is breathing out. And what we want to do is we want to calculate how much variation there is in E wave velocities as a result of the pleural pressure changes generated by respiration. So what we would basically do is we would find the biggest E wave and the smallest E wave, get the difference between the two, and divide it by the maximum E wave velocity. Okay. I say maximum and minimum because this will change inspiratory versus expiratory based on whether you're on positive pressure or negative pressure. So take the biggest minus the smallest, divided by the biggest velocity, and that will give you the variation, the respiratory variation of E-wave velocities. If you have respiratory E-wave variation greater than 25%, along with a plausible etiology for tamponade, like a big pericardial effusion, that is very suggestive of early and evolving tamponade. Okay, this basically is the ultrasound or Doppler visualization or correlation for pulsus paradoxus. So what you're seeing here when you see E-wave variation is pulsus paradoxus. Okay, so here's what it looks like. We've put our sweep speed to slow. We see a bunch of ENA tracings. We focus on the E-wave, which is the first of the two here. And we look at the biggest and the smallest. And if we calculate the variation between the two, it is 25% in this picture here. Quite conveniently, you have a plethysmography tracing here, which you will never have, but you can see that as the patient breathes in and out, there's a lot of variation in that E-wave velocity. And if you squint, you can see here, this is an apical 4-chamber view with a large looking pericardial effusion. So this big effusion combined with mitral inflow variation, very concerning for early tamponade. Okay. Keep in mind some of the pitfalls. These pitfalls are related to two things. One, it's related to the normal pitfalls involved with any Doppler technique. So imagine if you have a lot of translational movement of the heart, if the heart's swinging wildly back and forth as the patient breathes, which can happen during tamponade, then your theta angle for your Doppler is going to keep changing. And so that in and of itself will create a velocity variation, which is not necessarily due to tamponade. Okay, same story with irregular cardiac rhythms. So with irregular cardiac rhythms like AFib, by definition, you have variable filling. And so you'll have mitral inflow variation because of that, which may have nothing to do with tamponade. And secondly, think of all the things that cause pulsus paradoxus. So respiratory distress, high levels of positive pressure ventilation, RV pressure overload, all these things can cause pulsus paradoxus. So all these things will cause mitral inflow variation, which would be independent of any sort of tamponade effect. All right. So just to sort of summarize how these things are useful, this is sort of the evolution of tamponade on ultrasound. Okay, so up top here you have early tamponade, down here you have late tamponade. Sensitive indicators, specific indicators. Okay, so first, of course, you have whatever etiology is causing the tamponade. So you have the development of the pericardial effusion, for example. The next thing you get is mitral inflow variation. So you'll see that greater than 25% variation in mitral inflow velocities or pulsus paradoxus. So that is the earliest, most sensitive echo indicator of tamponade physiology, mitral inflow variation. As the tamponade gets worse, as it evolves, you will then develop right atrial collapse. So the second earliest or second most sensitive indicator of tamponade on echo. As the tamponade continues to get worse, you will then see the characteristic diastolic right ventricular collapse on echo. And then finally, as things get worse, you will start to see hypotension. Okay, so this is when it starts to actually become clinically apparent on vital signs. Okay, so your early indicators of tamponade, mitral inflow variation, more sensitive, less specific. Your later indicators, more specific, less sensitive. Okay. If you have any questions, as usual, please come find me or shoot me an email. Otherwise, I look forward to scanning with you.